Tractional retinal detachment can prove to be challenging even to the most experienced and skilled surgeons. Vitreous liquefaction, as we all know, is a natural process of aging and leads to posterior vitreous detachment. Tractional retinal detachment is the play between this detaching posterior vitreous and the proliferative tractional membranes. Before planning the surgery, a thorough systemic evaluation of associated factors such as diabetes, hypertension, anemia, etc. plays an important role. The preoperative clinical examination helps us in identifying the extent and nature of the detachment, associated vitreous hemorrhage, subhyaloid hemorrhage, and the plane for proliferative preretinal membranes.
These changes can be better appreciated on multicolor imaging.
Preoperative imaging like the OCT and B-scan can be a helping tool as well. The preoperative OCT gives us the overview of the difficulties which we could face intraoperatively and also helps us in evaluating the planes of the tedious preretinal membranes. While every surgeon would hope for a patient's retina to look like this, what do we do if we come across something that looks like this, or even this? Worry not. Here are some tips. We start off with our 3-port pars plana sclerotomies. Now, the vitreous in such cases is usually detached in the mid-periphery but will have attachments at the posterior pole, thus forming a cone. So, it's preferable to start by trimming the peripheral vitreous cone all around. Remember to use high cut rate and a low suction. Avoid pulling on the vitreous without trimming the peripheral vitreous, as it can sometimes bleed and may also cause tears in the retina. If vitreous hemorrhage is present, it is cleared off in a standard fashion. Always ensure that your ports are free from the vitreous strands. Now that we have cleared the peripheral vitreous, we move on to the posterior pole. There are various methods by which the membranes of the posterior pole can be dissected. The choice of the technique depends on the individual case. En-bloc dissection basically refers to the removal of the posterior vitreous and the tractional membranes in one piece. While this technique may be quick, it is best avoided as it can lead to multiple large breaks and profuse bleeding. Segmentation refers to the breaking up of membranes and removing them piecemeal. Modern-day cutters, which have their pods closer to the tip, facilitates this by creating a space between the membranes and the retina. In eyes where membranes are firmly adherent, we switch over to segmentation scissors. By placing one blade below and one blade above the membrane, they can be divided. Delamination can be performed in several ways depending on how firmly the adhesions are to the underlying retina. So the membrane can be peeled with forceps, or even the cutter can be used as forceps to suction the edge and peel it. Some simple tools like MVR blade can also be helpful in dissecting the membranes. The bent tip of the MVR blade helps us to create a nick in taut hyaloid, gives access to the subhyaloid space. Also, the bent edges helps in cutting and peeling the tough membranes. When utilizing the forceps, use short and gentle pulls. Avoid pulling aggressively as it may tear the already fragile retina. Use cutters carefully while dealing with flat proliferations. Because of their proximity to the retina, the risk of developing iatrogenic breaks are very high. Due to vascular nature of these membranes, bleeding is inevitable. Timely and judicious use of diathermy can prevent bleeding from going out of hand. In eyes with extensive membranes or those cases which take bad turn intraoperatively, bimanual surgery comes to the rescue. A fourth sclerotomy is made and a chandelier endoilluminator is inserted. Forceps are introduced through one of the superior ports and the edges of the membrane is lifted while the cutter or the scissors are used in the other hand to segment or delaminate the membrane. The forceps here are used to stabilize the membrane. One should remember not to pull with it or this may lead to tears. In densely adherent membranes, perfluorocarbon liquids may be injected to provide counter traction and flatten the retina, which can also help in hemostasis.
Also, in selected cases, pre-operative anti-VEGF can reduce the risk of bleeding intraoperatively. It is always better to peel internal limiting membrane wherever possible to ensure that the posterior pole is free of membranes.
For an associated macular hole, the ILM peeling should be done with inverted flap technique over the hole. Sometimes the presence of the subretinal band could deter the reattachment of the retina and thus should be identified and removed in toto. Finally, in certain scenarios where complete membrane peeling may not be possible, or if retina appears stiff and intrinsically contracted, a relaxing retinotomy can be done in order to settle the retina. Further, endolaser has to be done for all pre-existing as well as iatrogenic breaks. Supplemental endolaser should also be done in areas devoid of the laser. One must ensure that there is adequate hemostasis. Finally, endotamponade such as silicone oil or gas may be used. Keeping these points in mind, one can hope for a successful outcome even in the most challenging cases. Thank you.